I'm Dr. Nathaniel Chin, and you're listening to Dementia Matters, a podcast about Alzheimer's disease. Dementia Matters is a production of the Wisconsin Alzheimer's Disease Research Center. Our goal is to educate listeners on the latest news in Alzheimer's disease research and caregiver strategies. Thanks for joining us. Welcome back to Dementia Matters. Today we're highlighting a key speaker and presentation from the Wisconsin Alzheimer's Institute's 20th annual update in Alzheimer's disease and related dementias. I'm joined by Dr. Ronald Petersen, director of the Mayo Clinic Alzheimer's Disease Research Center and the Mayo Clinic Study of Aging. He is also a professor of neurology at the Mayo Clinic College of Medicine. Throughout his research career, he has authored over 1,000 peer-reviewed articles on memory disorders, aging, and Alzheimer's disease, and earned numerous accolades for his work, including the 2021 Lifetime Achievement Award for Alzheimer's disease therapeutic research. As part of the WAI's annual update, Dr. Petersen gave a presentation titled Mild Cognitive Impairment, a Construct in Evolution, discussing how the field's definition and understanding of mild cognitive impairment and cognitive decline has developed over time. Dr. Petersen, it's an honor to have you on Dementia Matters.
Well, thanks very much for including me in this discussion, Nate. I look forward to the visit.
Well, you have accomplished a lot so far in your career, but I'd like to go back to the beginning and have you share with us why you got started in this particular field. Why Alzheimer's disease and cognitive disorders?
Well, that's an interesting question, Nate, and certainly in retrospect, it looks like a well-planned pathway, but in fact, the appropriate term to describe it is serendipity, things that happened along the way. So I won't bore people to death with this, but I did start an undergraduate school with a focus on cognition, memory, psychology. But if this were a visual presentation, you could tell by the color of my hair that I've been around a while. So I graduated from college around the Vietnam era. So at that point in time, I was going to go to graduate school. I was actually going to go to the University of Michigan, but the military would have intervened. So I had been working at Honeywell in the summers and during my senior year, and they offered me a position, a full-time position in Honeywell, which would give me a brief deferment, at least for a period of time, so I could organize my life, because they were doing Department of Defense research. So I did that. I stayed in St. Paul and enrolled at the University of Minnesota in the graduate program. And soon into my first year at Honeywell, then I became aware of a program in the Army that would allow me to finish graduate school and then go into the Army in a professional capacity for an additional 4 years. So I applied for that, was accepted, finished a PhD in what would they call now cognitive neuropsychology. So that was my beginning entry into learning, memory, normal cognition, and the like. I then spent 4 years at the Army's Biomedical Research Laboratory in Maryland doing psychopharmacology, so drugs and memory, and that was evolving, very interesting. And the folks around me said, gee, if you really like doing this work, you probably should become a physician. So I applied for medical school, came back to Minnesota, went to Mayo Medical School, did an internship at Stanford, residency in neurology at Mayo, and a fellowship in behavioral neurology at Harvard. Then came back to Mayo. So if you look at that pathway, it was cognition, memory, learning along the way, which evolved into the medical aspects of that. Then going into neurology seemed like the appropriate specialty, subspecialization in Alzheimer's disease, and hence that's where I am now.
And you kind of went all over the country in order to get that training.
Absolutely. East Coast, West Coast, back and forth. Yeah.
But you are a Midwest person now, and we're going to claim you for those of us that are in the Midwest.
Absolutely. I can even go further. I was born in Wisconsin. I was born in Milwaukee. So my family moved to Minnesota early on, but I am a Wisconsin native, so to speak.
Nice, nice. Now, I've never heard you say it in any of your presentations or conferences, but many researchers and clinicians in the field have told me that you are the creator of the term and concept that we now call mild cognitive impairment, or for our listeners, it's more commonly called MCI. For our audience, I want to say that this concept of MCI is really one of the most important in the field. And as a clinician who sees people in a memory clinic, it's absolutely essential in talking to people with cognitive change. Because of this term, MCI, it is not about normal versus dementia. It is about a spectrum of change that emphasizes cognition as well as daily function. And it has really allowed for us to address stigma, help people with reversible causes, and truly prepare people for the future. So, my obvious request for you, Dr. Petersen, is to please summarize your years to decades of work into 2 minutes on how you discovered MCI.
A real challenge, but I'll try. First of all, people have been too kind. We didn't actually invent the term mild cognitive impairment. It was really coined by Barry Reesberg and colleagues at the New York University, the late 70s, early 80s. But they attached it to a particular stage in a scale that they'd been using called the Global Deterioration Scale. So, stage three, they called mild cognitive impairment. We then, here at Mayo, studying in the Mayo Clinic Study of Aging, which is a population based study here in Rochester, Minnesota, really came to recognize a group of people who were, as you say, Nate, kind of in between. They were aging, but not quite normally, yet they clearly did not have dementia. And so we captured these people and put some boundaries around them, being that one, they were memory impaired more so than they used to be, and maybe more so than they ought to be compared to normative data. Other cognitive functions were relatively well preserved, their function was well preserved, and they did not meet criteria for dementia. So we kind of characterized them and took the NYU term of mild cognitive impairment. But when we published this paper in 1999 characterizing these, people sort of jumped on the fact that we had put out these criteria. And I think that's really where it took off. A lot of controversy around the fuzzy edges and all that. But that was the essence of it. And then we expanded it in subsequent years.
And for our listeners, then, and I want you to correct me if I'm wrong, Dr. Peterson, really this criteria, and as I say it in clinic, is someone experiencing a thinking change. I like to say they've had the courage to come in and be tested because we know how traumatizing that could be for a person. And that testing has to show some lower scores compared to the norms that you're using, but they are functionally independent. They're still doing the things that they're doing. Is that correct? Am I missing anything?
That's a pretty good description of it, right? I mean, I think I usually say to people that to the casual observer, they really look normal, more normal than not. But they know, and people around them know, that their memory and thinking is not quite what it used to be, and maybe not what it ought to be, and consequently, it is a change for them. I think the key thing is a change. So, somebody could still be scoring in the normal range on normative data, but this is a change for them to where they used to be, and that's the key feature of it. And so while we use normative data, it's really the notion that people are changing more than what we would expect for aging, and of course that can become a dicey call. So you in the clinic, I don't remember as well as I used to. I have trouble with names and multitasking, things like that. Where does aging end? Where does mild cognitive impairment begin? That's a bit of a challenge, but you kind of get a clinical feel for it. And neuropsychological cognitive data can help you. It doesn't make the diagnosis, but can help you with that. But most importantly, MCI is a syndrome. So it's a collection of clinical features, not a etiologic diagnosis. Just like dementia. Dementia is a syndrome, and it can be due to Alzheimer's disease, but it can be due to other things. Similarly with MCI, and given MCI is a milder stage of cognitive impairment by definition, a lot of other things can cause this. Aging, medical disorders, COPD, my diabetes is out of control, things, medications I'm taking for my other conditions may contribute to mild cognitive impairment as a syndrome.
And another clarification question for you. Mild cognitive impairment is not pre-dementia. Someone can have mild cognitive impairment and not be on this path towards dementia.
That's exactly right. So as a syndrome, there can be treatable causes of it. And I think one of the things that you and I have come to appreciate in our practices in recent years are sleep disorders. People with undiagnosed sleep apnea can have cognitive impairment during the day. Once you identify their sleep disorder, treat it, they can go back to normal. So it need not lead to dementia, although often in aging, it is the earliest form of a cognitive disorder that will progress on to dementia.
And I'll have a question for you later on about that. Before I get to it, now this term, MCI, has been refined multiple times since its original use. In what ways has the field improved upon its meaning in both research or clinical care?
Sure. So early on, as I was describing it earlier, it was largely focused on memory because we were thinking about this being the earliest clinical presentation of Alzheimer's disease. But then we came to appreciate not everything is memory. Now, even though patients may come in and say, gee, I'm not remembering as well as I used to, when you drill down, it could be a language disorder. They're really having prominent anomia. They may have trouble concentrating, so it's an attention executive function problem. So, as we refined the construct over the years, we went into an amnestic form and a non-amnestic form. And then with the amnestic form, meaning memory is the primary feature, you can have other cognitive domains impaired to a lesser degree, but that fell under the amnestic MCI domain. But there is a non-amnestic MCI domain, could be the forerunner of a language disorder, attention concentration, even visual spatial skills. So for example, dementia with Lewy bodies at the MCI stage may not be a memory problem. You may have cognitive difficulties in attention, concentration, and visual spatial skills. And that is sort of a footprint of evolving Lewy body disorders, which can go on to dementia with Lewy bodies, but there is an MCI stage for that. So we tried to look at it again as a syndrome with memory, without memory, and are there other cognitive domains impaired as well?
And it seems like the earlier you are in thinking change, the more sensitive or helpful those thinking tests can be in sort of separating what is amnestic, what is non amnestic. And those patterns can be helpful to specialists in sort of getting closer to what the underlying cause is, since we can't get into the brain right now and look for those changes.
Right. No, absolutely. I think clinical acumen is important here. And you can do some of this in the office. You may need a neuropsychologist to help you out, really characterize which domains are involved and to what extent they're involved. That gives you the best signature of what this MCI might be. But you're right that there can be multiple presentations, and the better characterization you can give to it clinically, the more likely you may be thinking, well, this might be due to this or due to that.
That really emphasizes the importance of people coming in sooner to really address their thinking concerns, these changes that you've described.
Because they might be treatable. There might be very easily identifiable, treatable causes that can return them to normal.
Now, in 2018, there was a foundational change in how scientists viewed Alzheimer's disease. It went from being a clinical entity with some persistent element of uncertainty, since we can't do a brain biopsy, or we don't do that for sure, to a biological process with sort of clinical staging. Can you expand on how this change in the landscape has impacted MCI?
Yes, this was a research proposal, still remains a research proposal, meaning that it's not really adopted in the clinic yet. But the authors of that paper proposed that Alzheimer's disease be defined on its biologic basis, that is, by the presence of amyloid and tau. You could pick it up by biomarkers and the like, or at the time of autopsy, but in life with biomarkers. But that was independent of the clinical presentation. So this is a big deal. This changes the field rather dramatically because now it's saying that somebody who is clinically normal but harbors the biologic changes of amyloid and tau would be labeled as having Alzheimer's disease being normal. Similarly, at the MCI stage and the dementia stage. And the proponents were saying, we're trying to put Alzheimer's disease on the same platform as other medical disorders. So if you have a biopsy of your prostate and it's positive, you have prostate cancer. Whether you're symptomatic or not, you have prostate cancer, breast cancer, and the like. So they're saying if in fact we have evidence of the biologic underpinnings, you have the disease. Well, that takes a lot of adaptation for all of us. They did say, though, that there still is a parallel corresponding clinical spectrum, and the clinical spectrum could be cognitively unimpaired, MCI, dementia, or they also proposed a 6-stage scheme for people who are amyloid positive. Stages 1 and 2 were sort of normal cognition, 1 being squeaky clean normal, 2 being normal, but I'm experiencing some subtle changes. Stage 3 was kind of MCI. 4, 5, and 6 were mild, moderate, severe stages of dementia, but they're not part of the definition. They just go along in parallel to the underlying biological spectrum.
In your presentation, you mentioned that MCI is, quote, bouncy, which I think is a very good way of describing it. And in research, we certainly tell our participants this. But what do you mean by bouncy? And in essence, is MCI truly a precursor to dementia?
Yes. So in our longitudinal studies, and certainly you have them in Wisconsin, the RAP study, your ADRC, follow people longitudinally over time. So in our Mayo Clinic study of aging, we've been following people for up to like 17 years now. Not many, but some out many, many years. We make our diagnoses independently each year, independent of their previous diagnosis and independent of their history of cognitive testing. As such, this early diagnosis of mild cognitive impairment might be subject to the bounciness. That is, I may see them this time, they look like they have subtle cognitive impairment. I'll label them MCI. In fact, they just had a bad burrito for lunch. Okay. Next year we see them and they're squeaky clean normal. So that's the bounce. But we've also looked at these data longitudinally, as you have. And in fact, when a person is once identified as having mild cognitive impairment, odds are they're on the road, that things are going to decline. They may go back and forth, but ultimately, following people out 8 and 10 years, 2/3 of those who bounce, if you will, ultimately declare themselves as having MCI going on to dementia. Other studies, the cardiovascular heart study out of Pittsburgh, has identified the same features. I characterize it like, labile hypertension. Okay, up and down, but odds are you're going to go down. Glucose intolerance, normal, abnormal, normal, abnormal, but you may be on the road to diabetes if you don't do something about it. And I think of MCI much along the same line, that it's sort of a warning that things may be brewing. There may be treatable entities, but if nothing is done, it may progress in the future.
I'm glad you added that last sentence because I was wondering while you were saying that, well, what if it is sleep apnea? We identify it, they get treated. We've seen that in clinic. People return and have completely normal testing and continue to not have symptoms.
Exactly. So if there are medical elements, especially as folks get older, their resilience, their ability to respond to medical insults, fevers, infections, things like that is lessened, and it can affect your cognitive function. But that doesn't mean you're on the road to Alzheimer's disease.
So, how common is mild cognitive impairment?
We looked at the literature, we meaning a committee from the American Academy of Neurology, looked at the literature about 3, 4 years ago, and it's a huge literature. We had over 11,000 studies to look at. Now, we culled that down to a few hundred that met the very strict criteria for an evidence based medicine review of the literature. But these were international studies, population based studies, and we actually found that there were probably 20 studies that met class 1 criteria for prevalence, which is outstanding when you do an evidence-based medicine review of the literature. And we came to the conclusion that MCI in people 65, 70 and older, the prevalence was probably in the 10 to 20% range. We at Mayo have found a 16% prevalence in our population 70 years and older. So I think that's probably a good ballpark figure for individual. Again, this is MCI as a syndrome, not Alzheimer's disease, but as a syndrome, it's probably in the 10 to 20% range in the appropriate age groups.
And people often will ask, particularly in a clinic, well, what's the progression? How many people or what percentage of people progress to dementia every year or over 5 years? What do you say in your clinic?
Again, it depends on the source. So if people come to a physician, seek out the physician, so to a memory disorders clinic with that concern, then the rate is probably 10 to 15% per year if there's an underlying neurodegenerative process. Now, if it's one of those treatable conditions, then all bets are off. But if it's an underlying neurodegenerative disease, probably 10 to 15% per year. However, if the people are identified in an epidemiologic study, like we do here, so we go out and knock on their door, would you like to participate? Then the rates are a bit lower. I'd say 8 to 9 to 10% per year. You're finding it sort of as it exists in the community. But if people are seeking care, come to the physician, it's probably a higher rate.
I think it's so important to emphasize that context matters. Who is coming into a clinic? Are you, as a researcher, going to them? Because that does change how you're looking at progression.
Absolutely.
And speaking of progression, if someone, let's say in this case, does have Alzheimer's disease that is causing the symptoms that we are characterizing as MCI, and they eventually do progress to dementia, but how long do people typically live in the stage of MCI?
Again, good question, relevant clinical question, very variable, of course, but we've had the luxury of following people in the study of aging here who started out in the study as cognitively unimpaired, progressed to MCI, continue to follow them, they progress to dementia. So we looked at their so-called dwell time. How long were they in that state? And again, large variability, about 3 years. So ballpark figure that people will hang around in MCI for 3 years, but that can be very variable. And there are more aggressive forms, but in general, the 3 to 4 years is probably a reasonable estimate.
And we talk a lot about lifestyle interventions on this podcast, so I don't need you to go into great detail about any particular one, but I am wondering which ones you think are most impactful for people living with mild cognitive impairment.
I think that this actually is an important issue because I tend to view aging as not necessarily a passive process. That is, we can do things about the course. I don't go as far as to say that if I run 3 miles a day and eat blueberries, I'm going to prevent Alzheimer's disease. I can't say that. But I think we can impact the trajectory, and especially if somebody has mild cognitive impairment. So I'm sure you've covered this, Nate, but aerobic exercise. I think that's probably the best one. I think there's a good deal of biologic evidence, epidemiologic evidence that aerobic exercise, maybe with some interval training, a little strength exercise as well, may in fact have an impact on the rate at which we progress. We, of course, talk about staying intellectually active. So keeping the mind working one way or another. I'm not sure one brain game is better than another. Recent paper in the New England Journal touted crossword puzzles over some brain games. Maybe, but I think keeping active is a good thing. Maintaining your social network, staying out with the family, doing things, avoid the tendency to withdraw. I think we also emphasize good sleep hygiene, as we've already talked about, and then a reduction in over excessive stress. So I think these kinds of lifestyle factors, again, diet comes in, but I think here again, I'm not sure there's any supplements or anything that's particularly useful. A good heart healthy diet, a Mediterranean diet maybe is probably the best bet. But I think a combination of these can actually have an impact on the rate at which we might progress if we have mild cognitive impairment.
Now, clinical trials in Alzheimer's disease are moving earlier and earlier along this cognitive change spectrum, with MCI being of great focus and importance. What are your thoughts about amyloid removing therapies in people living with mild cognitive impairment?
A very timely question, Nate. Just came from the Clinical Trials in Alzheimer's Disease conference in San Francisco, where I think some very exciting data were presented on one of the monoclonal antibodies called lecanemab that actually showed it did remove amyloid from the brain over the course of the 18-month study. Others have shown this, aducanumab, that received the accelerated approval last year. Another one was presented at the meeting, gantenerumab, which removed some of the amyloid. Another one, donanemab, will read out in early 2023. So I think these monoclonal antibodies do what they're supposed to do. They do reduce the amyloid plaque level in the brain. But the study on lecanemab last week really talked about the fact that it may slow the progression of the disease. Doesn't stop it, doesn't make anybody better, but it may slow the rate of progression. They estimated about 27% slowing over the course of 18 months. And interestingly, in all of these monoclonal antibody studies, the majority of the people have the clinical diagnosis of mild cognitive impairment. It varies as to the percentage, but this is the predominant stage of the disease at which they're intervening with these antibodies, and it appears to be helping. So, again, these are not cures for the disease by any means, but in this particular study, the primary outcome measure, the four secondary outcome measures, all positive. And they projected that over the course of about 18 months, you may have a 4.5-month slowing of the disease process. So, then we get into this argument about, well, is that a big deal or not? Well, I think for people with mild cognitive impairment, if they can maintain again their overall level of function, given the inconveniences of the memory problems, but they can still drive, pay their bill, do their taxes, that's a big deal. And if we can prolong that period for them, I think we've done a clinically meaningful benefit for them. So I'm excited that these new studies now are really intervening in a meaningful fashion, and I'm hopeful that we'll get even more of these available so that we have something to say to our patients that in addition to the lifestyle factors, we now can intervene pharmacologically. And it'll probably take a combination of these to really work.
In your presentation for the WAI, you also commented about this cumulative effect in that the study can only speak to the 18 months, but if you truly change the rate of progression of a disease that is progressive, later on, there could actually be a greater benefit relative to people who are not taking the medication. Did I say that correctly?
Yes, you did. And there is a certain amount of assumption there, the progression that the curves are diverging. So the treatment curve is flattening and the placebo group is continuing to decline. Now, we don't know that. We're most comfortable staying within the data. But if we extrapolate out, and in fact, these curves are diverging, we might in fact see a greater benefit 2 years, 3 years out. Now, I don't say forever. I'm not sure that these are going to remain linear, but I think over the course of the disease process, since we talked about a 3 year duration earlier, if we can extend that out by 6, 12, 18 months, I think that might be meaningful for our patients.
And to end our conversation today, I'd like to hear your final thoughts on the future of cognitive disease research and clinical therapy. Where are we going and what still needs to be done?
Well, I think really the field is making tremendous advances. I used to say that I think we're doing a better job on the diagnostic side than we are on the treatment side. That's probably still true. I think the clinician's acumen using some of the tools we discussed. I think the advent of biomarkers has been big for the field of Alzheimer's disease, so that we can now identify who might have amyloid in the brain, who might have tau, and other features, other medical comorbidities, maybe other neuropathologic entities that may be present, so that we can talk to our patients and say, here's what your syndromic appearance is, mild cognitive impairment dementia, and here might be some of the contributing factors. We think you may have amyloid, tau, etc. I think ultimately, though, that we shouldn't focus too much on any single disease like Alzheimer's disease, because almost everybody has a combination of factors. So maybe some amyloid, maybe some tau, maybe some alpha synuclein forming Lewy bodies, maybe TDP-43, which can impact the brain in the medial temporal lobe, and vascular disease. Almost everybody has some element of vascular disease. So likely down the road, in addition to perhaps some disease modifying therapies for the individual proteinopathies, I think we'll end up with a combination of therapies so that we'll start treating these disorders with a biomarker profile that tells you have a certain amount of amyloid, you have a certain amount of TDP-43, and here's what we're going to do about it. Now, this is not today, tomorrow, but I think that's the direction in which we're heading. And perhaps people will come to their geriatrician, their primary care physician, to get their lipid screen, of course, but also get their cognitive screen, where their profile of biomarkers will be presented, and hopefully then we have some therapies to intervene. And I think I may have said in the presentation that we do this now with hypertension. Somebody has elevated blood pressure. Well, how do we treat that? Well, could be a diuretic, could be a beta blocker, calcium channel antagonist, angiotensin receptor blocker, ACE inhibitor, et cetera, et cetera. Different mechanisms to treat the same symptom. And I think cognitive function and cognitive impairment may be that symptom that's ultimately going to require combination therapy to attack it.
Very exciting. And with that, thank you, Dr. Petersen, for being on Dementia Matters, and I certainly hope to have you on in the future.
My pleasure, Nate. Thanks for having me.
Thank you for listening to Dementia Matters. Follow us on Apple Podcasts, Spotify, Google Podcasts, or wherever you listen. Or tell your smart speaker to play the Dementia Matters podcast. Please rate us on your favorite podcast app. It helps other people find our show and lets us know how we're doing. Dementia Matters is brought to you by the Wisconsin Alzheimer's Disease Research Center at the University of Wisconsin-Madison. It receives funding from private, university, state, and national sources, including a grant from the National Institutes on Aging for Alzheimer's Disease Research Centers. This episode of Dementia Matters was produced by Amy Lambright-Murphy and Kaylin Rowerdink and edited by Hao Ming Meng. Our musical jingle is Cases to Rest by Blue Dot Sessions. To learn more about the Wisconsin Alzheimer's Disease Research Center, check out our website at adrc.wisc.edu. That's adrc.wisc.edu, and follow us on Facebook and Twitter. If you have questions or comments, please email us at dementiamatters@medicine.wisc.edu. Thanks for listening.